Thank you all for coming. This is the first live one we've had for 3 years. So what I did is I went back for 4 years as far as what are new medications. So I'm not going to talk about things like Botox. I'm not going to talk about a lot of the medications we've been using for years, but I'm going to talk about some of the newer medications. Now, in order to understand the newer medications, you have to understand what the migraine cascade is. So this is a picture like what Mandy showed a little bit earlier, but I'm going to go into it a little bit more detail and show you what happens normally with a migraine, and then as we go along with the medications, I'm going to show you how the medications stop it. So I want to thank AbbVie, number one, for this slide. Okay, so what we have here, this is the trigeminal nerve, and this is the presynaptic and postsynaptic. So what happens is an impulse travels along the trigeminal nerve, and when it hits here, it releases the neuropeptides. One of the neuropeptides, this little green one, is the CGRP, and there's other ones like substance P, VIP. But the CGRP is felt to be the most important as far as migraine goes. So what happens is it's released, and this is the CGRP. These green things are the CGRP receptors. So if it hits the CGRP receptor on the postsynaptic terminal, it provides impulses that go to the brain and gives pain impulses to the brain. CGRP also it has smooth muscle cell. It's in a blood vessel. If the CGRP hits there, it causes vasodilatation. It also causes inflammation in the blood vessel. So that's what happens. That's what happens with a migraine. You get inflammation and vasodilatation. If you don't stop that, that's where you get the pain from. It's from the blood vessels themselves. Okay, so let's talk about some of the new medications. Let's go symptomatic treatment first. Symptomatic treatment is where you take a medication when you get the headache. It decreases the frequency, it decreases the severity and the associated symptoms of the migraine. So the biggest one that we have that are new are the GPANTs. And this is Ubrelvy and Nurtec ODT. So these medications, let's go back to this right here. What these medications do is it's an oral medication. It's a small molecule that blocks the CGRP receptor right here and right here. So it prevents the propagation of pain signals, and it prevents the blood vessels from dilating. It also stops the inflammation. So in other words, it shuts down the whole cascade. And both of them work the same way. Let me go back for a second, because let me talk about some of the older medications, because I'm going to compare the GPANTs with the triptans. So how do the triptans work? When the triptans came out, we did not have this all down the way we do now. But what happens with the triptans is they are serotonin 1B and 1D receptor agonists. They work at the receptor. So on the presynaptic terminal, you've got a 1B receptor, and the triptans bind there and prevent the release of CGRP. So, first of all, what this tells you is the earlier you use it, the better it works. Because if you've let out all your CGRP and you use the triptan, that's not going to do any good. So we found this out early with the triptans, is the earlier you use them, the better they work. Also, what happens, the serotonin 1B receptor is on the smooth muscle cell, the blood vessels. And when you activate that, it causes vasoconstriction. Okay, so that stops the vasodilatation. The problem here is it doesn't stop at normal, it constricts it even more than it normally would have. So the problem here is that if you have coronary artery disease or cerebrovascular disease, it can cause problems. So that's why these drugs are contraindicated. Okay, so what's the difference between the GPANTs and the triptans? Well, first of all, the GPANTs have fewer side effects. Most of them have nausea about 4%, or the triptans can have side effects 30 to 50%. It can be nausea, drowsiness, pain behind the nose, tightness of the jaw, tightness in the chest. So when the triptans first came out, they were very good because we didn't have anything like it. But as we went along, not everybody did well with the triptans. So the Gepants come along and they have fewer side effects. So in patients who don't tolerate the triptans, you can use the Gepants. The Gepants don't really cause rebound. So the triptans, if you use them more than 2 days out of the week, it will cause rebound and keep the headaches going. The Gepants don't do that. Now, why does that happen? Nobody really knows for sure. The triptans are agonists, meaning they activate receptors. The Gepants block receptors. So it's felt that if you activate receptors, you can cause the rebound. If you just block it, you don't cause the rebound. So again, you can use the Gepants every day, and you're not going to cause worsening of your headaches. The big thing here is the Gepants can be used in patients who have cardiovascular disease or cerebrovascular disease, and it's safe to use in stable disease. So patients who have had a heart attack, they've had strokes, and just because you're in older individuals doesn't mean you're not going to get migraines. What Mandy was talking about before, like with menopause, the hormones are only one trigger for the migraines, okay? And usually you have a lot of other triggers. So the tendency to have migraines doesn't go away when you stop the hormones. It's just one less trigger. So patients that are older, a lot of times we don't use the triptans because it can cause problems with cerebrovascular disease or cardiovascular disease. The Gepants you can. So those are some of the advantages of using the Gepants. Another new category is a ditan, and the one of that is Rayvow. Rayvow is lasmiditan, and what happens is that lasmiditan is a serotonin 1F agonist. So it works right here, the same place that the triptans work, and causes a decrease in release of the CGRP. However, it does not work on the smooth muscle cell. So in that regard, the ditans can be used in patients with cardiovascular, cerebrovascular disease. The problem with the ditans is that they do cross the blood-brain barrier and can cause central side effects, drowsiness, dizziness, and it's recommended that if you take one, you don't drive for 8 hours. Okay, in my book, the whole purpose of taking a medicine for your migraine is to make you more functional. This doesn't make you more functional. However, if none of the other medications are working, it's better to be non-functional and not have a headache than to have the headache and be non-functional. So it does have a role. So those are the new symptomatic treatments. For prophylaxis, of course, we have the monoclonal antibodies. Now, these are 3 and 4 years old, so they've been around for a while, but I figured it's new enough that we could talk about them. So we've got Aimovig, Ajovy, Emgality, and Vyepti. Of those, Vyepti is the newest one, because I think the last time we met in 2019, the other 3 were available. So there's some differences between all of those. Aimovig is a monoclonal antibody against the CGRP receptor. So it binds the receptor. The other 3 bind to CGRP itself. So they have the same mechanism of action. They keep the CGRP receptor from being activated, but in different ways. The first 3, Aimovig, Ajovy, and Emgality, are given subcutaneously, and the Vyepti is given IV every 3 months. And the only other difference is that the Ajovy is another one that can be given every 3 months. You get 3 shots every 3 months instead of 1 shot a month. So those are the major differences. There's nothing that suggests the person's going to do better with one than the other. I've had many patients that have gone on one and because of insurance reasons have to switch, and they do perfectly well. Others that one works much better than the others, so there's no way to predict. Okay, so it doesn't matter which one is started. We could try any of them. Okay, so back to our little drawing here. This is the Aimovig right here. It binds to the CGRP receptor and keeps the CGRP from binding. And these is the other ones where it binds to the CGRP itself and keeps it from binding. Now, the major difference between binding to the receptor and binding to the ligand, the binding to the receptor, the Aimovig can have some side effects that the other ones don't have, particularly constipation and also hypertension, high blood pressure. We don't see those as much with the other ones that we can see with Aimovig. So the G-PANTs that we talked about before can also be used prophylactically. And we've got Nurtec, which I talked about before as being for symptomatic treatment. It's the only medication that's now been approved for both prophylaxis and symptomatic treatment. So you can use it for both. And it's very useful in patients. You can use it as needed, or if you have an incidence where you know that the patients are going to develop headaches, there's a storm system coming before tests, for menses, and also some of our patients that get Botox, they get a wearing off of Botox 2 weeks before the Botox is due. It's good you give it prophylactically for that. So it's a very interesting drug. And the other one's Qulipta, which is another new one, but it's only for prophylaxis. So you take that one every day. You take the Nurtec ODT every other day. And again, they work here and here to block the CGRP receptors. Okay, so those are the main new medications. We have older medications that have come out recently with new formulations or new delivery systems that's worth mentioning. So we've got one that's Tosomra, which I have to say I've not really used that before. I know it's available. It's a sumatriptan nasal spray, but it's formulated with intervalve technology, which helps it absorb better than the regular sumatriptan nasal spray. There's a saying from headache doctors that the sumatriptan nasal spray was a funny way to give an oral medication because most of it runs down the throat and is absorbed orally. So it's not well absorbed. So the Tosomra, it's absorbed a little bit better. There's Zipzor, which is diclofenac. It's a liquid in a capsule. So, of course, just like any other medication you put liquid in a capsule, it gets in the stomach, dissolves, and the liquid is absorbed fairly rapidly. Diclofenac is a non-steroidal anti-inflammatory, so it works very well. Alexib is a liquid formulation of Celebrex. So Celebrex is another non-steroidal. It's a liquid. You drink it, and again, it's absorbed quickly. It's also for migraine. There's also talk about re-releasing an old non-steroidal Vioxx. Vioxx was one that was actually approved for migraine, but it was taken off the market because of cardiovascular problems. Well, all non-steroidals carry a warning about cardiovascular. And the reason for bringing it back is if you're using it for migraines and not using it every single day, like for arthritis, the risk is not as great. So they're talking about bringing that one back. And the last one I want to talk about is Trudhesa. Now, Trudhesa is DHE. It's a nasal spray. DHE's been around since the 1940s, and we had a resurgence of it in the late 80s when we started using it IV in the hospital to break headaches. They cannot really make it as an oral medication, but in the 1990s, we had a nasal spray, a DHE nasal spray, that we had high hopes for, but it never really worked out that well. In the early 2000s, we were promised an orally inhaled DHE that we talked about for years. Oh, this is coming, and it never came. And there was problems with the delivery system. But that one is much closer to the IV levels. So now the Trudhesa it's nasal, but it's much closer to the IV levels. And so let me show you. It's actually the same medication as in Migraine nasal spray. So it's the exact same medication. So the one on the left is the regular nasal spray. And what happens is you spray it, and it stays in the lower nasal cavity. And the blood vessels are not that good there, and it's not absorbed as well. With the Trudhesa, it uses the pod delivery system. That's the one on the right. And when you activate it, it goes into the upper nasal cavity, and it's absorbed much better. So here's, when you give IV DHE, here's what it looks like. This is the concentration, and this is time. So you get a very high level, and then it evens up. This high level is why you get side effects with the DHE nasal spray, why it causes nausea. Okay, so here's what happens with the regular DHE nasal spray, the Migraine. It comes up, but it never reaches the same level as the IV, which is why it was not as effective. So then you get the Trudhesa. So within 30 minutes, it has the same level, serum level, as the IV, and then stays the same. So that's why it's much more effective than the Migraine nasal spray. So we do have an effective way to give DHE, particularly in patients who don't tolerate the triptans or even the Gepants. Okay, and that's, in a nutshell, those are the new medications that we've got available.